ଆଚ୍ଛା ଦିଶିବନି ତାଙ୍କୁ ଦେଖାଯିବନି
ନାଇଁ ଆଫ୍ଟର ଇଣ୍ଟରାକ୍ସନ୍ ଆଫ୍ଟର ପ୍ରେଜେଣ୍ଟେସନ୍
ଆଚ୍ଛା ଡିଷ୍ଟାନ୍ସ ଠିକ୍ ଅଛି ଏଇଟା
ସାର୍ ସାର୍ ସାର୍
Hello, good afternoon ladies and gentlemen. Today we'll be discussing on the Peri Operative Fluid Management in children and now they can
sir,
see
sir.
this. Peri Operative Fluid Management in children as such be more challenging as compared to adult because children have a different physiology. So initially we'll try to understand the physiology of fluid therapy before going to the clinical aspect of how to manage and how much and what. So first of all, let's understand why do we need fluids. As we know, the fluids excrete the solutes and end products of metabolism. But the primary function of fluid in the body is to maintain cellular function and energy production. That is, like say, the substrates from the food that we eat in the form of glucose, fat, protein, they are transported through the bloodstream, as well as oxygen through the RBC transported to the mitochondria into the cell to produce energy to sustain our life and for growth and development of our life. That is possible provided the fluid in the intravascular compartment, interstitial compartment, and
You can continue.
And the intracellular compartment are balanced. In case there is any deficiency in the either intravascular compartment or intracellular compartment or the interstitial compartment, then there will be hampering of the movement of oxygen from the lungs to the mitochondria where the energy is produced. So to maintain the cellular function, the fluid balance in the three different compartments are very equally has to be balanced. This is a diagrammatic representation of the body circulation from the lungs to the tissues. The common belief or common perception is the aim of fluid therapy or primary goal of fluid therapy is to maintain the intravascular compartment so that there's adequate circulation. If that is the goal, that can be inadequate to reach to the tissues unless this is matched with equally balanced intracellular and interstitial fluid therapy. So goal of fluid therapy is not the maintaining the intravascular compartment. Goal of fluid therapy is to allow oxygen, transport oxygen from the lungs to the tissue through this mechanism by a balanced fluid management between the intracellular and extracellular compartment. To recap a bit of our physiology, the fluid is distributed in two spaces in the body. They are conceptual spaces, they don't have anatomical boundaries, but they are either inside the cell or outside the cell, intracellular and extracellular. And they are in a dynamic state of equilibrium and it is a continuous process. And this dynamic movement is determined by the osmotic forces and it can be differentiated with different stress factors. These spaces are, if total body waters, the intercellular compartment is 40% and extracellular compartment is 20% in adults. Intravascular compartment is 5% out of this 20%. As compared to this, in children, the intracellular compartment is 40% and extracellular compartment is 20%. It is just the reverse. This reason what commonly people believe that children cannot tolerate fluid is actually a myth. Just say imagine you have intracellular compartment is a let's see intracellular compartment, and between the and this intravascular compartment, this is the adult value, whereas this is the pediatric value. This is the fluid which is more freely movable into the intravascular compartment when there is a hypovolemia and blood loss. If this is the situations where the free movement of fluid from the interstitial compartment to the intravascular compartment, more fluid is available for replacing the intravascular compartment. So they can tolerate much better. Only thing is we detect it late. By the time we detect it could be too late. Come to the fluid. The movement of fluid from the intravascular compartment to the extravascular is almost free. You know that this capillary wall is a monocellular. We cover the details again. Monocellular epithelium. So except the difference between the intercellular compartment or fluid and the intravascular compartment fluid is basically almost identical except proteins and RBC which cannot move beyond the cell wall. So if there's a loss in the intravascular compartment, is easily replenished from the interstitial compartment. As compared to that, moving fluid from the intercellular compartment to extracellular compartment is not so easily available because there is an energy mediated mechanism of movement of sodium and fluid from the interstitial compartment to extracellular compartment. Though it happens in the extreme dehydration. So this control of fluid balance is achieved by modifying and manipulating the easily accessible space, that is, the intravascular space. Imagine a big hall with a small window. If the hall is huge, but we can see through the window, we may not be able to see the appreciate the whole entire hall. Similarly, when you look at the intravascular space, that is not enough to tell us about the entire fluid balance in the body. How to manipulate this interstitial compartment, intravascular compartment? So this is the only access available to us freely to monitor, to replenish, and to maintain the balance. This is by manipulating the volume, capacity, and osmotic properties of the intravascular compartment. Okay, now let's come to the other factors which influence the fluid shift and ultimately patient management. What are the physiological factors? Most important physiological factor is the movement of fluid from the one compartment to the other is Starling equation. You are familiar with all. The oncotic pressure and hydrostatic pressure are the most important factors. We know in the capillary, the arterial side and venous side, when the fluid moves, the fluid passes through interstitium and then it transfers the oxygen and substrates. And endothelial cells are monocapillary, or walls are monocapillary cells with pores or slits which opens depending on the physiology condition, like for this hypoxia or acidosis, it will open it up more fluid will go leak out. So to maintain this status, now this is a electron microscope view of the endothelial cell wall. What was believed earlier to be a monocellular or cell wall is not true. Actually, there's something more to it, than what is normally believed all these years. So there is a hair-like or columnar hair-like structures in the wall, capillary wall, which is a glycocalyx matrix. So in the vascular lumen, and this, the fluid is distributed in the flow in the vascular lumen. When there is some static amount of fluid, it remains, and the proteins remains in the endothelial glycocalyx. So how this reacts and how this barrier acts or helps in movement of fluids across the capillary wall is yet to be very clearly understood. But certain fact that we know is that this Stirling equation is not the same or as simple as it used to be. It has to include the same hydrostatic and oncotic pressure in the glycocalyx to have to factor beyond this other two pressure in the interstitium lumen and oncotic pressure in the interstitium lumen. So these factors, which is called say delta low, this factor is equally important when you transfer. So the layer of ciliary wall acts as a barrier. The endothelium is highly dynamic cell layer that is involved in a multitude of physiological functions, including control of vascular tone, the movement of cells and nutrients, maintenance of blood fluidity, and growth of new vessels. And they are affected by ischemia, reperfusion, hypoxia, reoxygenation, inflammatory cytokines, proteases, arterial nutrients, peptides. They all degrade these cell wall. Whereas sevoflurane, hydrocortisone, and antithrombin has been seen to protect this. It has some protective effect on the glycocalyx. So the equation needs to be revised with the new understanding of the physiology. So it is slightly more complex. This glycocalyx is not uniform throughout the entire vascular structure throughout the body. If you see, this is the glycocalyx, and they are fenestrations. These fenestrations are different and different tissues. So this is a nervous system, muscles, and conduct in the lung, where the fenestration is almost non-negligible, whereas in liver, spleen, and marrow, they are very big fenestrations, very large fenestrations. So there in between are the endocrine, choroid plexus, gut mucosa, and glomerular areas. So this amount of fluid movement between the capillary through the capillary wall depends on the degree amount of fenestrations available. So the movement is not uniform all throughout the body. This understanding will help us to understand the movement of fluid from the intravascular compartment into system in different organs. So to summarize, so this will be a new Stirling equation where taking the endothelial cell layer into considerations. The second important factor in our understanding of physiology, which likely influence the fluid therapy, is the new understanding that we used to believe that the blood is circulated into the arterial side, which transfers the oxygen and the substrates and the arterial capillaries, that is absorbed in the venous side and transmitted through venules. Which new understanding tells us that this is not true. What happens is the fluid moves from arterial to the interstitial compartment, to the venous side, and the oxygen and the substrates move into the interstitial space. And this fluid interstitial system is not come back to the capillary, that is absorbed by the lymphatics. And for the movement of lymphatics, a fluid is so heavy, is as much as 5 to 8 liters in the body per day. So this understanding, like for example, in case of hypoproteinemic edema, it was commonly believed that if you administer albumin or proteins, the fluid from the intestine will come back to circulation, which may not be true because the doesn't come back. Whereas if you're enhancing the lymphatic circulation, these fluids might come back to circulation again, the proteins might come back to circulation again, though a bit dilatedly. What are other factors? Other factors which influence fluid therapy is ability of the kidney to concentrate or dilute, the capacity of the vascular compartment, like younger children has compartment is lesser because it has not opened up, because unless the muscular activity increases, the peripheral vascular compartment is not well developed. Cardiovascular status, integrity of blood-brain barrier, hypovolemia, hypoxia, and acidosis. These are factors which influence fluid therapy. Renal factor, maturation takes place by the age of 1 month, which is as good as an adult. So this is not a great factor, except the neonates. Rest of the life, this is not such a big factor. Clinical factors, a patient has preoperative jaundice, which is jaundice means loss of appetite, not less of fluid intake. Same is in esophageal and gastric lesions. A patient is vomiting. If there's a fistula from the bowel, and a patient is going for surgery where patient is bowel washed, where the accuracy of input and output is difficult to maintain. So these are the situations where patient might come in a hypovolemic state. In bowel wash patient might sometimes come a hypervolemic state as well. Besides then, when the patients come for surgery and anesthesia, what do we do? A surgery anesthesia, we fast the patient or child, which leads to fluid deprivation. All the drugs that we use for induction of the patients leads to hypovolemia or relative hypovolemia. In the intraoperative period, because of under anesthesia, there's a decreased metabolic need, and there's increased antidiuretic hormones, so there's a fluid retention, plus there's a fluid loss and blood loss depending on the tissue dissection. All these factors impose additional influence on the fluid management in the intraoperative period of a varying degree. Normally, the fasting starts 6 hours before surgical conditions in older children for solids, and 4 hours for less than 6 months. This is solid basically is milk, and for clear fluid it is 2 hours for both age group. A patient is properly followed the fluid regime or feeding regime. That means a patient is fasted just 4 hours or 6 hours and not more than that, and if given some fluid 2 hours before, there's no need to provide extra fluid in proper feeding regime is followed. But unfortunately, in our country situations where the patients come from home, might recover few hours before coming to the hospital, and it's very difficult to control this feeding regime, so they might need some extra fluid for that purpose. The drugs that we use intraoperatively, thiopentone, propofol, halothane, Civo, morphine, all of them are produce hypovolemia. Even blocks in older children like epidurals, subarachnoid may produce hypovolemia. When a patient comes in the preoperative period with relative hypovolemia, this is more pronounced when the patient is not properly resuscitated in the preoperative period. A patient resuscitated preoperative period, the hydration cell in this child is not adequately hydrated before surgery. At induction, the hypovolemia will be more marked. So now come to the therapy or how to manage this fluid. We'll discuss into 2 headings: how much fluid what type of fluid, and when to infuse. The fluid concept of fluid therapy has come from a physiological understanding that 1 ml of water is needed for 1 calorie metabolized in the body. Based on this concept, the Holiday and Seeger has devised this maintenance fluid formula for children, which all of you are very familiar with. However, this is a very arbitrary and empirical formula which may not be true and is too complex to calculate all the time in all the patients. In fact, over the years, they have changed their recommendations to that it may not be correct. The new recommendation says correct deficit with normal saline 20 to 40 ml per kilo, half of average maintenance fluid next 24 hours, maintain daily plasma sodium concentration. So you must understand the Hawley and Seeger are not anesthetists, surgeons, or intensivists. Who are the people normally who prescribe fluid in the perioperative period? They are physicians or pediatricians, and this recommendation is for a normal, healthy child admitted to the ward. And this is maintenance fluid, whereas a surgical patient is completely different and they have very much different dynamic fluid situations as compared to normal, healthy child. In fact, the maintenance fluid can be administered in a single formula 4 ml per kg per hour across all the children, including neonates. This was initially advocated by Frederick Berry, who is a professor from Virginia, and it's much simple, easy to calculate, and easy to remember. The maintenance fluid as such is a very small amount of fluid as compared to the other losses in the body and the replacement fluid in the intraoperative period. The first hour in the intraoperative period, you might have read in the book sometimes that some of these recommendations are you gave so much of fluid for starvation, you starve for 6 hours, so gave 6 hours of maintenance fluid to the patients, 50% first hour, next 25% second hour, next 20% third hour. They're all stupid. If you have given a fluid 2 hours or 4 hours before surgery, you don't calculate the starving or fluid deprivation from the time you have given the feed. Your starvation is calculated from at least 3 to 4 hours after giving initial feed. So if you give first hour, if you give 25 to 15 ml in 15 to less than 15 kilo is 15 ml, more than 15 is 15 ml, or less than 15 is 25 ml per kilo. This will take care of all the fluid requirements, all the deficits, and all. In fact, this is slightly conservative. You have to titrate in every patient's requirement differently. Besides that, in the intraoperative period, when the area is exposed to atmosphere, there's a large amount of insensible fluid loss from the atmosphere because the temperature difference and from the body and atmosphere. Besides that, when you use dry gases for breathing in the intraoperative period, we lose a lot of water through the lungs. If you are not using artificial nose or heated humidifier or a filter, this could be very, very high. Depending on the damage of capillaries that during dissection of the tissue handling, or use of diathermy or degree of trauma of the different variety of degrees, there could be a huge amount of third space loss. There's a group of German groups who believe that third space doesn't exist, but which may not be true in the intraoperative setting. Normal healthy individuals, probably there's no fluid in the extra spaces, whereas in the intraoperative period, when there's perioperative period, there's always loss of extra volume where there's capillary damage. Means when the capillary is damaged, the fluid leaks out from the intravascular compartment to the interstitium, and it comes back only when the capillaries are repaired. So if this is Beyond second hour, the fluid therapy is recommended is maintenance 4 ml per kilo, and depending the degree of tissue trauma or the stress, 4-6 ml per kilo is additional to 4 ml of maintenance fluid. If patient has blood loss, then you transfuse blood or replace. A blood loss is less than 50%, you replace the loss with crystalloid or colloid, 1:3 times blood loss and 1:1 time loss of colloid. This is a standard recommendation. We'll come to that slightly later. Coming to which type of fluid is needed. These are different types of fluids available in the market. 5% dextrose, 4% dextrose in 1/5 normal saline, 4% dextrose in 1/3 normal saline, Ringer's lactate or Hartmann solution, normal saline, serofundin, plasmolite A. All these fluids, all these years, when I was a resident, when glucose was the first drug of choice or first fluid was introduced to the patients, whereas present day, glucose is not used as a routine practice because what we have understood is stress of surgery and anesthesia produces hyperglycemia and decreases the peripheral utilization of glucose. So if you use glucose as the first fluid, what do? You don't achieve anything except to receive more hyperglycemia. The second understanding that hypoxia injury to tissue is more pronounced in patient receiving glucose. That means a patient has received glucose in the tissue level and there is some degree of hypoxia at the tissue level, injury could be more pronounced in those patients where glucose is small. This is not a common thing, but this can happen. This understanding has come from patients who are survived initial resuscitation. Those who are given glucose did not survive as many as the one who didn't receive glucose in the emergency wards. But so routine practice, glucose is not indicated in children. However, there are certain patients like children of diabetic mothers or diabetic child who has got a history of hypoglycemia. They need some glucose intraoperatively. Those children who are on parenteral nutrition, their glucose level is very high. If you don't give glucose, there will be a mismatch between the glucose and insulin level in those children. So patients who are on parenteral nutrition should be given glucose. Neonates need glucose definitely. What is commonly believed is this is the phase where growth takes in a very rapid fashion. So if you look at the pediatrics books, they say on neonatal books, 6 to 8 or 4 to 6 milligram of glucose is necessary every minute, which intraoperative period, which may not be true. And we don't know yet how much glucose is necessary, but what we recently did a study to see it 2.5% of glucose is good enough for maintaining glucose level and not depleting the normal storage of glucose in the body in neonates. There are recommendations for 1%. Some people don't use at all. So probably 2.5% is good enough to prevent any hypoglycemic episode. For the other fluid, means besides, if you're not giving glucose, what are the ideal fluids? Because the interstitial fluid loss or intravascular fluid loss is identical to physiological salt solutions, are identical to the interstitial fluid, Ringer's lactate, serofundin, and plasmolite A are considered almost close to the interstitial fluid or serum. However, there's a bigger difference. Ringer's lactate has very low sodium and high chloride. Serofundin has slightly high chloride, whereas plasmolite is more close to a serum. But if the patient is not getting very high volume depletion, high replacement, it really doesn't make much difference. There's a big controversy you must have read or heard and studied about crystalloid and colloid. Should you give crystalloid or should you give colloid? This controversy is unnecessary because colloid as well as crystalloid are normal constitutions of body fluid, and they are both needed. Only you have to identify which one is needed when. Like all the major cases, we can start with crystalloid, whereas those children where blood loss is more than 50% of blood volume, you can start with colloid. In neonates, albumin 5% is preferred over synthetic colloids. It's commonly believed that if you give colloid, the intravascular fluid remains in the intravascular compartment a longer period of time, thereby maintains the intravascular volume for a longer period of time, which probably is not true. In this study, if you see, which was published in Lancet Long 2007, a patients who are normovolemic and if you hypervolemic, a patient receives colloid. In a patient when is normovolemic, they are volume or hypovolemic, their volume goes up. Whereas in normal patients, the volume doesn't increase, means a patient is hypovolemic, colloid increases the intravascular longevity of the colloid. Whereas a patient is normovolemic, almost 70% of colloids leaks out into the interstitium. What is our goal? When you give this fluid, if you see this graph, this is a very interesting graph depicting the perioperative morbidity risk. In the normovolemia, has got a minimum risk, whereas morbidity risk increases, whereas presence of hypovolemia or hypervolemia. So we have to maintain the volume in this range. That should be our aim. Presently, the intraoperative fluid is influenced by case reports, anecdotes, and tradition of a particular hospital rather than, or tradition of institutions rather than any rigorous scientific and clinical investigations. And now we understand that intraoperative fluid management may influence postoperative outcomes. So, to summarize, at the moment, the way we practice fluid therapy in children is an exercise in empiricism, means it's all empirical without any much of scientific evidence. This reason you have seen all these nomenclatures: conservative fluid therapy or standard fluid therapy, restrictive fluid therapy, liberal fluid therapy, without exactly defining what is restrictive, what is liberal, and what is conservative. These terms have come up from different authors, different individuals, without much very clear-cut definition standard. This is actual review published a few years back in BJA. How much fluid is too much? The learning point from this review is both too little and excessive fluid during the intraoperative period can adversely affect patient outcome. Greater understanding of fluid kinetics at the endothelial glycocalyx enhances insight into bodily fluid distribution. Evidence is mounting that fluid therapy guided by flow-based hemodynamic monitors improve perioperative outcome. It is unclear whether crystalloid or colloid fluids or a combination of both produce an optimal patient outcome in what clinical context. That means if you are instead of crystalloid or colloid, it should be a mix of both depending on the individual child's requirement. So what sort of fluid and how much fluid is amount of type of fluid necessary should be goal directed, individualized to individual patients, and procedure specific. Means a surgery, a hernia patient, a thyroid patient, or a patients for coming for tonsillectomy, and patients for liver dissection will have a different requirement for fluid therapy. Goal directed means what is the aim or what sort of goal? We don't know the goal yet. Some people use the cardiac output or as a goal, which means flow directed, stroke volume or cardiac output as a goal to give fluid. Whereas we are not clear about it. Let's make it very clinically. In the perioperative period, fluid is needed in very major cases, whereas most of the time, there are a lot of people, if you maintain the fluiding regime, fluid is not required in minor surgical procedures like a routine hernia, circumcision, a cyst removal, lipoma removal, lymph node removal, or MNT and ENT procedures, UAI. They don't require any fluid intraoperatively. Some fluid is required in tonsillectomy, adenoectomy, open reduction, bone fractures, hand surgery, but challenging fluid requirement is only in a very small number of cases like hepatic rejection, major abdominal surgery, surgery involving chest, neck, cranium, scoliosis, and major bone surgery like hip and femur. The overall target of fluid therapy should be to prevent hypovolemia and subsequent compensating mechanism like rise in heart rate, vasoconstriction and fluid shift, and maintain macrocirculation. The means if patient heart rate has gone up, patient BP is low, if a vasoconstriction means there is decreased capillary feeding, which are signs of microcirculation impairment, that should be prevented, or that should be reverted back after fluid therapy. So thank you very much.
Any question from IGMC Simla and Haldwani?
Hello. Sir, are you selectively using plasma light in pediatric patients?
Say it again, please.
Are you using plasma light as a regular fluid or not?
Routinely, we use ringer's lactate and serofundin, and some patients plasma light. In normal routine cases, it really doesn't make much difference. Whereas the patient have much more volume loss and more dynamic situations, it might lead to hyperchloremia in serofundin and ringer's lactate. But in routine practice, major surgery, most of the cases, even ringer's lactate is good enough.
And up to what age of the children you are regularly giving glucose or dextrose?
Dextrose is routinely you don't use in any children except neonates. With neonates, we use 2.5%, 1 to 2.5% glucose in ringer's lactate or in serofundin.
Any monitoring, especially volume monitoring for pediatric age group for undergoing usual operations?
It's a very interesting question, because you must know how to assess how much fluid is adequate, whatever you've given is adequate or not adequate. In neonates or young infants where the fontanelle is open, it's filling the fontanelle, capillary fill, and skin turgor, urine output. They are the 4 very, very important clinical features which gives more information than heart rate and blood pressure. Blood pressure and heart rate are not a good reflex or good index of intravascular volume in children.
So what is the monitoring you are using? Flow directed monitoring you talked about.
Flow directed monitoring is not routinely used in practice. This is basically a flow directed monitoring of stroke volume monitoring is mostly a research oriented papers. Routine flow monitoring is not minus, but in sick patients like in cardiac cases, people people try to understand the flow by using transesophageal echocardiography, which is not routinely practiced in most children.
Dr. Pawar, what is the role of normal saline these days?
In children, normal saline is only used when other fluids are not available. If in case of dire emergency, the fluids are not available, whatever in emergency situations, whatever fluid is available handy should be used. Otherwise, it has no role normally.
In hemorrhagic shock, uh, what about colloids, especially like starch preparations?
In shock, starch preparations, actually, if you have enough of crystalloids, depending on how much blood loss has taken place. In blood loss is less than 50%, less than 50%, you don't have to be very, very aggressive. The ideal is the blood replacement. The fluid resuscitation is required only till such time blood is made available. That's the time you need active resuscitation. Otherwise, that time whatever fluid is needed or available is good enough.
A question sir, from Sirian. Is there any need for urgent operation to be done? Or second question, what will be the immediate
More questions?
into patients? Sarilan, is the applicant said, is there any need for urgent operation to be done? Second question, what will be the immediate response to patient due to lack of medical facilities?
तो fluid therapy से किसी relationship नहीं है. Hello.
Hello.
हाँ कौन?
Hello. Good
हाँ
afternoon,
बोलिए.
sir.
Good afternoon.
Sir, why not normal saline is being is using in pediatric population rather than renal lactate, especially in
Oh,
neonates?
yeah, how much sodium is there in normal saline?
154 molecular per liter.
And what is normal sodium in the body in fluid?
145.
So you can give more sodium and more
So
chloride.
not for resuscitation, for perioperative fluid management.
Even then, why should you give more? What is then needed? You should eat as much as you feel hungry about, isn't it?
So RL
there
is
is
slightly hypotonic also. Ringer is hypotonic also.
no. That is a hypotonic it's a misconception. If you see the osmolality, what is normal plasma osmolality? If you take
280 to
280,
310
no,
millismol per kg.
not up to 310. It's 285, 286, right? So if you see this sodium chloride is more than 300, right? Whereas Ringer's is 270 or 275. So it's very close. It's not a hypovolemic or hypotonic.
Yes, sir. Slightly. Okay, sir.
No, it doesn't make much difference. See, his
Sir, liver
tonicity.
maturity is limit in case of neonates. So lactate load in cases of neonates will be much more as compared to normal saline. And this hypernatremia, hyperchloremia caused by normal saline is managing that is easy as compared to lactate load in neonates.
Oh, I see. That's what you mean. Really, that's
Yes.
it's not true. If you are really concerned about lactate, you should use acetate. Serofundin is acetate.
Yes, sir.
Right? In case,
Okay, sir.
but it's not actually a issue. See, earlier days, people used to give normal saline a dextrose water to neonates, thinking that they cannot take care of sodium in the intraoperative period. Their kidney is not mature. But any full-term neonate can deal with sodium so long as sodium is not more than 140.
Okay, sir. Thank you, sir.
Right?
Yes, sir.
सर को थोड़ा बता दीजिए जो
देखिए कहीं बोलिए.
नहीं रिप्लाई बोल दीजिए सर.
Hello, there are some questions from Sierra Leone. Is there a need for urgent operation to be done? Operation for what? Not very clear about your questions. And what will be the immediate response to patients due to lack of medical facilities? And which type of patients? I think these answers to these questions are quite self-explanatory. If there's no immediate facility for surgery, then patient will have increased morbidity or mortality. So this has to be taken care of by transporting the patients to a center where the facility is available. Urgent operation is there a need for urgent operation to be done? For what type of cases? If there's a need for urgent operation, it has to be done. But it depends what is the surgical indication. Please let us know or elaborate or detail your question so that I can respond easily. Yes, please. Any other question?
Sir, any remarks about isolate P?
Isolate P is it should be banned actually. It should never be used. You know how much sodium in isolate P?
It's almost half of the plasma concentrations.
No, much less. It's around 70. So few years back there was a big issue in Ireland where they lost many children because of hyponatremia produced because of infusion of isolate P. And there's a big debate about banning isolate P in those countries. It should be banned actually, it should not be used at all, because hyponatremia is a silent killer. You understand two things from this fluid management which is very, very clear. One is the glucose need and the sodium need. What has changed over these years is there's no need of glucose except in specific individual or neonates, and sodium should be given adequately to children. Hyponatremia has been a silent killer in children in the perioperative period. So give adequate sodium, which is normal sodium, not more like normal saline.
Okay, thank you.
Hello.
Yes.
Hello. May I ask you a question? Yes, sir.
Sure.
Sir, you have told that in units where glucose is needed, you give 2.5% glucose. But how can you make this 2.5% concentration of glucose? How do you make this?
Oh, normally what you use is either if you are using ringus lactate or if you are using serofundin, whatever you are using, or acetate, you can add 10 to 20 ml of glucose in 90 ml of or 80 to 90 ml of fluid from 25% or 50% glucose. Take 25% glucose, right?
Yes.
Or 50% glucose, whatever available, and add 10 to 20 ml of serofundin in a burette. That's what normally we do. Or in a infusion pump, if you are using infusion pump in a 50 ml syringe, you can use 5 to 10 ml.
Okay. Thank you, sir. By this, you can avoid the dilution of the other electrolytes. Yes.
Yes. So that you don't dilute the other electrolytes. Right. Absolutely.
Yes. Thank you.
Any other question?
No, sir. Thank you very much.
Thank you very much.